So I'd like to invite our first speaker, Dr. Andy Curran, to set the scene for us. Andy.
Thanks very much, Mark, for that introduction. And as Mark says, welcome to Morecambe. This is partly my patch. I've lived down in Lancashire since 1998, work at one of the trusts down the road, and it's Associate Medical Director for Lancashire and South Cumbria ICB. See, this is very much my territory, but I have to admit I've never been to this ground before. Thankfully, the sat-nav got me here, and I did a nice loop round about the grounds because I decided to go left until I found the car park. So welcome to Lancashire. Just by being here, you're boosting our local health economy. And so really it's a good news story, because one of the things about health inequalities is that it's where money is spent. So the very fact that we're here today, we're going to be improving the inequalities in some of this area. So thank you just by being here or by being online. This picture was taken a number of years ago. Thank you. And funnily enough, when I was speaking to Dale before, reminiscing about time as a trainee, the way that we deliver medicine has changed a lot. We used to have a casualty service, and people used to be casualty officers. We then moved into accident and emergency, and now the speciality is emergency medicine. This is what I wanted to do when I grew up emergency medicine. It wasn't that I was a failed orthopedic consultant. It wasn't that I wanted to do something else. It's not that I still want to do something else. What we do in emergency medicine can make a massive difference on people's lives. We can also get it very wrong as well. And so with it comes a massive privilege for what we do. So, given that it's the opening address in today, I think it's really important for setting the scene, and I make no apologies for a number of graphs that I'm going to show. What I've tried to do is put some of the axes labelled to make it easier to see. And basically, the sad thing that this graph shows is that the more the deprived area you live in, the greater the number of deaths will happen in under 75 years. So dependent on where you live is going to make it more or less likely that you're going to die younger. Not about what you do, not about your genetics, not about whether you smoke, not about whether you exercise, simply about where you live and the circumstances that you live in this day and age, today, in this country. So we might have made lots of advances in things like emergency medicine and worried about what we call it, but actually have we made things any better? Because people will still die prematurely before other people because of where they live. That can't be something that's right. And that to me is what inequality is all about. Why should that be the case? So just in this simple graph, red means bad, green means good. And so each of those dots are different, what we call wards within Lancashire and South Cumbria, and that life expectancy. I don't know, did anyone come by the train today? One. Thank you. I'm saying nothing else because we're in a period of purder about public transport. However, I've used this graph just as a simple way of trying to illustrate where we are and thinking about some of the differences that can happen here. So Dale, I'm going to come to you at the end of this slide. If we report in the UK about deprivation and we lump everyone together, it's very hard to see individuals. If we speak about Lancashire and South Cumbria, we can speak about a level of deprivation. If we speak about within a city, we can speak, but we have to really get down and to know our population. It might literally come down to which side of the street you live on as to whether you're more or less likely to die before. So we cannot apply what we know to the whole population, whether that's of the UK, whether that's of the region, or whether that's just of one ward. We have to really know our communities well and know where we're going to focus and target. On this chart, again, the red means that you're more likely to die early, and the green means you're less likely. So, being that local, Dale, I was going to ask you, as a trainee moving around the region, we spoke about different places and different areas that you've worked. Do you see a difference in different departments, or now are we at the stage where everywhere is just as bad?
Really good question. So I've worked across Preston, Wigan, Bolton, but before I even went into training, I've moved around the entire Northwest, worked in Blackpool for a bit and rented a place there because, to be honest, they paid better because people don't want to go to the end of the road, as some people would describe it. And the fact of the matter is, in A&E, it doesn't really matter where you work or how the relative levels of deprivation around it. You're mostly still going to see the poorest people from those areas, but it is still worse if you're in places that have overall male deprivation, because the fact of the matter is if you have more privilege, you're less likely to get ill in the first place, so you're not that likely to need the services, or you're able to access services that are more appropriate for all your needs at the time, like going to the general practitioner and having things done in a more preventative manner. But there are noticeable differences in the sense of going to Blackpool on the kind of the frequency of the extreme levels of deprivation that you might come to encounter. But if I'm honest, working in A&E, you meet the local people who need us the most all the time as a baseline.
Thanks, Dale. And it's hard to imagine an emergency department or acute hospital that doesn't have a population that's deprived near it, that doesn't have a community that is going to benefit from looking specifically at that area. So, moving on, if we think about some of the drivers and why that's the case. So again, within this graph, I've picked out three big groups of conditions. The one on the left is about respiratory, the one in the middle, cardiovascular, and the one on the right about mental health. And in this slide, I'm not going to go into the detail about what makes them up, but just three generalized areas. There's a big variation, but it's not quite what I thought it would be. If you look at the one on the left, our more deprived communities and areas are down at the bottom in red, and there's a slightly greater number of respiratory illness within those compared to our less deprived areas. But look at cardiovascular. It's the other way around, so that there's more disease in our less deprived areas than in our more deprived areas for cardiovascular. And we need to think about what's making that up and what's driving it. But look at the one on the right, mental health. One of the key things that I've learned within my time recently with us forming as an ICB was Andy White coming in as our chief pharmacist. And he's named the medicine strategy what matters to you. So it's not what's the matter with you, but what matters to you. How do you feel? What's your view of it? How's your opinion? Not what I'm going to tell you that you are. And it's really crucial that we appreciate that someone's mental health has a massive impact on their physical health. We kind of know that, but I don't think we always accept that that's the case. My daughter at the moment, literally at this moment, is doing her GCSEs. I'm a bit of a nervous wreck, glad for the distraction of coming here, I have to admit. But she yesterday whacked her knee on the table, floods of tears about it. And it's more about the fact that she's stressed at the moment, and little things will then make her more upset. So whacking her knee in, it's broken, you've got to take me to hospital, I'm convinced it's broken. She managed to walk to the cupboard to get some Oreos. So as a good ED clinician, I instantly knew it wasn't broken. But there's that reaction. Depending on your mental health, if you have a slight physical health illness, it can affect you far more. But do we really focus on mental health when we think about physical health? Within Blackpool, there's some really great work going on with our health and wellbeing coaches. We employed people within the community to work within their community, because one of the key things is about your employment status and being in work and about your well-being. So again, the solutions is often within the community rather than us having to come in, apply other people because of the benefits that can happen. So remember what matters to you. Within this chart, again, we could spend a long time discussing each of these, and I've not put in the bar charts, but I just want to pick out the bar chart on the left. So that very tall column is our most deprived areas. The one next to it is our second most deprived areas. It is really start to see the difference that happens when you move into our most deprived areas. Now, it's all gradual going from the right to the left, with our least deprived at the far right-hand side, and a bit of an undulating line, but that big jump from our second most deprived to our most deprived areas, and this is about the number of long-term conditions that people have, whether they've got 3 or more. And the next slide, we'll look at what those long-term conditions are. But again, it's not this continuing line that we can look at. There are some real areas whereas if we know our community and look at our data, we can identify where we should focus. And this helps me realise that looking at our most deprived areas is where we should be focusing. So those long-term conditions are made up by a variety of areas. The very long bar chart here, turned the other way around so it's wide, is hypertension. Now, I'm not belittling how important hypertension is, because it leads to a number of end-stage diseases. But think about the screening campaigns that have happened. Think about people accessing healthcare services, thinking about what is often described as the worried well, going for a checkup. These might be people who are able to get into their local pharmacy. They may well be people that are going to the GP for something else and identified as having hypertension. We have to find people, and so this could actually be people from our less deprived wards who are seeking for that healthy wealth-being check, and that is driving up our numbers of hypertension. If people aren't accessing services, we will be missing them. So we've got to think about the offer that we make. Right, here we are. This is probably my killer slide and the crucial one for me to think about. Thank you very much to my population health team at Langston South Cumbria that they are embedded in this, they live this, they work with this all the time. But it helped me get my head round something called priority wards and exemplar wards and what we're doing. So all the English local authority wards are represented in here with a little dot. And the scale that goes from left to right is about the deprivation score. So again, I've put in the bar chart, the less deprived you are on the left, the more deprived you are towards the right, where the red and the blue and the greens are. And the number of admissions is up the left-hand side. So a bit like with mortality, the more deprived area that you live in, the more likely you are to be admitted or attend an emergency or urgent care provision. What I do want to do is focus on that far right-hand side, where that spread of dots seems to get really quite wide. So remember, these are our most deprived wards. So the red dots are the outliers where we're getting significantly more admissions than might be expected even for, and this is a horrible term, but for their level of deprivation. So comparing them with other equivalent wards with the level of deprivation, that they are even more likely. And these are what we call our priority wards, where we really need to focus on the communities. Now, the good news story are the green dots below. So again, same level of deprivation, but where we've got a reduced number of admissions. What are we doing right in those areas? What are those communities benefiting from? And those are our exemplar wards, where we need to learn from them. What's happening that's doing right? So it's not all bad news. There is good news there, but don't forget these dots represent where someone lives. They might not have chosen to live there, and why should they have a different level of expectancy because of where they live? Coming back to that. So Keith, I'm going to come to you with this slide, and I'll let everyone just read it for themselves. Being poor means that people are more likely to experience respiratory conditions that increase mortality rate, reduce life expectancy. Being poor. 2024, the UK. So Keith, my question to you is, what do you think is the public acceptability of clinicians factoring wealth to stratify health interventions, so targeting where we do interventions dependent on someone's wealth?
Well, pretty obviously, if you've got the money and the resources are there, you shouldn't have any problems, provided you can get hold of a GP, I should think. I think it seems to be a big issue, no matter where you are. So I heard on Radio 4 this morning. But living in Blackpool and for the 9 years I attended a day centre in Claremont, I saw all types of poverty and deprivation, and particularly Blackpool's an exceptional case because of the transient population, and for different reasons they want to come and live in Blackpool. They want a good time, if you're ill or not, but also the living conditions for some people, and I've seen that for myself, was dreadful. I don't know if it's the same now, that because I'm not quite as involved as I used to be. So I don't have an answer. I'm just thinking about what you were saying, and I've referred to Claremont. When he's no longer my MP, Scott Benton got removed. So he put on a sort of session at Bloomfield Road, and I asked the lady from the day centre on Dixon Road in Claremont, how have you been since Clark, Collaboration for Leadership in Applied Health Research and Care? And she said, it's worse. But I didn't get a chance to say, why is it worse? I believe Revo in Blackpool is now the poorest ward for problems. It seems to change all the time. It used to be Bloomfield, as I remember. I don't really have an answer to this. It's just ongoing. I mean, everything. I've been looking at the graphs and I think, oh, more graphs. We've seen all this before, and certain things. I've just commenting this morning. We're talking about the same things we talked about 10 years ago. So I don't know what the answer is to this situation.
It does feel like we need to do something, knowing this knowledge, knowing that makes a difference.
One thought is, I live in the deprived area, but I'm in the west end of the deprived area, not the east end. That is more deprived, which I know it very well. And it's up to the local authority as well to tell you if they really care about what's going on.
Yeah.
And what I wanted to mention was, many years ago, I was at an event around drugs and alcohol in Blackpool, and the people responsible from the drugs and alcohol teams, I said, is it the transient population? No, these people have lived here for years. They pass it on from one generation to another. I thought, oh, right. And I've experienced that in where I live, that some of the, sounds like I'm being judgmental, parents need guidance. So
No, thank you. There's definitely the generational aspect as well in what we learn. You mentioned about local authorities. Thank you, because local authorities do have a big part, but they're not the only part. And again, there's something about all of us having to do it. This graph is just basically giving us an idea that it's not the fault of old people. I sometimes hear it demonized that our population's getting older and that's what the problem is. That's not what the problem is. We need to think about healthy life expectancy. And yes, our population might be getting older, but it's not quite as extreme as sometimes we're made out to think with these inverted pyramids, etc. The chart on the right, the pinks are just showing where we've got increased numbers of populations in our different bands, but some of our population ages will be going down. But far more focus should be on our healthy life expectancy, not the total number of years. So the number of years before we develop a long-term condition. And when we have a long-term condition, remember going back to the what matters to me, does it stop me from doing what I want to do? So, very busy slide, which we're not going to go into the detail of, and Mark, I'm going to come to you at the end of this one. You're welcome. Basically, this is showing within Lancashire and South Cumbria where we predict are going to be the issues that come up for us. And it's going to be cardiovascular disease, obesity, and people that are having falls. Now, again, we have to be careful of data. So these are not necessarily people that have been admitted to hospital. They're people that will have had a fall at home. So not everyone goes on to have a fractured neck or femur after a fall or require admission because of some of the services that are in. But just projecting it, there's some conditions that are going to increase more than others. So again, it's the cardiovascular disease and obesity that if we don't do something about it, we'll see the greatest increases. The other conditions in the yellow and the red, thinking about mental health, we're not likely to see the same great increase. So it's not everything is going to increase the same way. So Mark, I was going to come to you and ask about, have you seen an increase in the age of those attending in the EDs? And if so, what impact does that have on the department?
Well, I work in the Wirral, which is a strange place because it's got big areas of deprivation, some of the seriously deprived areas in Europe, but it also has some of the richest. I remember my first patient being 90 years old who'd just come off the golf course, who'd collapsed. And I asked him his past medical history. He said, oh, nothing. When was the last time your GP? Probably about 5 years ago. And then I'm thinking, are you sure? Maybe this guy's got dementia? And no, he'd just come off the golf course. He wasn't on any medicines. But then you've got the other people who are chronologically 40, but actually 90 in real age. I think it is becoming an issue. And I think that really we need to make sure there are good frailty services which almost need to grow because of what the growth is going to be with cardiovascular disease, with dementia, with falls, to be able to deal with that and then move on to think about how we can actually prevent that happening again. So instead of, yes, you didn't have your neck or femur this time, but next time you might. So we really need to think about services in the community that can help prevent and work towards safer ageing, really. So absolutely, age is a big issue. And unfortunately, at the moment, because of bed situations, it's not very good to be in a hospital when you're elderly. You're losing muscle mass, you're losing confidence. So the amount of people who do fall, but then actually their confidence in living is affected because of that one fall.
Yeah.
So absolutely age is we see a big age problem within the emergency departments.
And as you say, prevention is better than cure is one of those things that we have to think of with the emergency admissions as well.
Can I have just one small point?
You can, but if we go over time, it's your fault.
And so on like frailty services, class and ageing, or I've just introduced the word class because, my mom's very frail for her age, really, at 62. And because she's from the lower classes, and I'm from there, but here now, she wouldn't be entitled to access a lot of frailty services because they add age cut-offs, which are inherently discriminatory towards people who come from more deprived backgrounds. So, my call to people here is actually we need to change that. It needs to be based on need, not on age, because chronological age is not the same as physiological age. And that's really wrapped up here, so I just felt like I needed to add that. Thank you.
No, thank you. Very true. So, Mark, you had mentioned about fractured neck or femurs. Just going to have a little look at this, but almost going to go against the age aspect because I'm going to think about under 65-year-olds. Often we think of older people with fractured neck or femurs. But this was done by colleagues of mine down the road at Preston Hospital. Rennie, who's actually now just recently retired as a physiotherapist, living his best life, travelling around Europe, presenting this work. And Kirsty, one of my ED consultants, a self-confessed geek. But they're looking at under 65-year-olds and their mortality at 30 days, but also all the way up to 5 years. And just the headline figure really is that the people from the most deprived wards and the middle deprived wards are far more likely to be dying after they've had a fractured neck or femur than the people from the least deprived wards. Now, interestingly, from the long-term condition aspect, it's not quite as stark between the very most and the middle deprived. So we have to be careful about lumping different wards together. We can aim for what's happening in our middle wards and saying that's acceptable, because in this case, they're getting just as bad an outcome as people from our most deprived wards. So we've got to be very careful and think about looking at disease-specific aspects rather than lumping together. So within the conclusion that they made, and Renée's email address is in there, I'm sure they'd be more than happy for any questions, or you can send them via me because we're not spending long on it. Being less than 65 and having a hip fracture is bad news. Kind of knew that already, but this research shows that the drivers are deprivation and associated comorbidities. And Carter said this back in 2003 that this was the case. So Tony, I'm going to come to you just for a last question from us, but thinking about what do we do for trying to manage people on a less emergency basis, but whether people are coming in as elective admissions, do we factor in their deprivation beforehand and tailor what we're doing to enable them to get back to normal life faster?
I think the short answer to that is probably not. And just thinking about kind of neuroscience care, we have kind of real problems in the way that we organise care and integrate care across different bits of the health service, and see people coming to the emergency department, and often their attendance in the emergency department is really a failure of ambulatory care, and that people's ability to access care is often inversely proportional or proportional to their levels of deprivation. So I guess you've highlighted the contribution that deprivation is making to people's health and the downstream consequences of that. And we need to be working together in an integrated way to fix so many problems, which is why I think it's great that we've got this session ad hoc, because we've got a really important opportunity to think about what is our collective responsibility for tackling the health inequalities and consequences, and often we see those in secondary care, and secondary care organisations are heavily impacted by deprivation and health inequalities, but don't often see themselves in a place where they can actually bear influence on them.
Thanks very much, Tony. So just want to say thanks very much for your attention today and your time. QR code there if you want to scan. It will go to my email address, and happy to take up any follow-up questions that way. And if anyone online also wants to contact me that way, more than happy. Thanks very much.
Been trying to keep an eye on the chat. Problem I've got is I can't move up and down the chat, so there have been comments about the impact of these problems not just on the index person but the person caring for them, and the wear and tear on the people who are caring for people who are struggling with multiple conditions or dementia and living in areas where there isn't enough support and they don't get the right type of care packages. There are some comments about what cardiovascular conditions may be due to, and I think there is an association with affluence and greater risk for cardiovascular conditions to some extent, but not entirely, because poor diets are often the worst rather than better. But I think there's some mix around that. And there have been comments in here about digital deprivation as well, and that people, we know from our work in the household health survey we did in Clark, which is the predecessor to the ARC, we did about 7,000 households got surveyed largely in areas of deprivation, that something like 20 to 25%, it was Jenny's work, didn't have stable access to broadband and internet, particularly in the older population, but also that was to do with poverty. And we know from, as practices in general practice, that very often the mobile numbers we have get out of date, particularly in the poor areas, because people don't have regular access to a stable telephone number, which reflects the fact they're getting a pay-as-you-go when they can afford it. So there are lots of issues, and this shift of saying, well, AI and digital is going to solve everything, that just isn't true for the sorts of populations we're talking about here. So that's sort of what's coming up on the chat. What I think is becoming very clear to me about why this is a particularly interesting topic for the day, and people might have thought, why we're looking at A&E? Well, A&E is that interface where people bump into health when a crisis happens. And what we're looking at is why these crises are happening when we think we're providing good quality community-based care. And I am a GP and I am biased, and the point has been made yet again, there aren't enough GPs. There seems to be a determination to cut general practice out of the NHS. 90% of the patient contacts are in primary care for 8% of the funding, 8. And the money going into general practice per patient has halved since 2008 in real terms. That's why you can't see a GP. That's why you can't get an appointment. The money's being sucked into the acute sector to cover waiting lists, and those long waiting lists bounce back into primary care and fill primary care so that we can't take those proactive moves to doing those home assessments, doing that multidisciplinary care, and actually providing that community-focused attention to those people at the greatest need, particularly in areas of high deprivation, where there's even less resources going to primary care. I think there's some really interesting areas for discussion here about how we can be looking after those people who are struggling the most. I think we need to move on to the next speaker, but thank you very much, Andy. I do have time, before we move on, to take maybe 2 quick questions to Andy, if there are any in the room. So, start with yourself.
I've got very complex needs. My question is, why is it that do I never see one GP? Why do I see about 6 different GPs?
I can answer that, because we're being pressured.
I'd like to open up the question.
Okay, so the answer to that is because the target is for people to be seen quickly, not to see the same person. And so the pressure on general practice is that people are seen as quickly as possible, and you can't do that and provide continuity. There are very few continuity appointments. You have to free them all up to hit the government target that there's less waiting time to see a GP for the reason that's just been stated. So it's almost impossible to do both with the current workforce. And the number of GPs has dropped in the last 10 years, not gone up. And despite a 10% increase in population. Andy?
Hiya, I'm Andy Pennington. I work in Liverpool with Mark. I'm a health inequalities researcher and have been for over 20 years. Just to note on that last point, of course, Mark knows, it actually, when you turn GP surgeries as per policy into conveyor belts, and you have an increase in complex patients, comorbidities, etc., you actually waste time and waste money, because as a patient with complex needs, you have to go in every time and spend the 10 minutes explaining your history. Whereas when we used to have the same contact GPs, of course, your GP knew you and probably known you all your life. So it's a terrible false economy, but an important point. I wanted to make a point and ask you what you think about it. So I think I've been in health inequalities research for over 20 years, and it's easy to become kind of jaded. And I think we have as a society. So, because I'm in public health research, of course, I've seen the patterns of population ageing and increased morbidity and increased multi-morbidity, and the crisis in mental health turning into a catastrophe in mental health, etc. over time. But there's this acceptance in society that we can't fix this, that waiting lists are, you know, really difficult and they will just go up and up and up. But those same forces were in play between the late 90s and in the noughties, and waiting lists were reduced. And at the same time as we have an ageing population, we also have a larger population and a really record low rate of unemployment, and we have more people working and more people paying taxes. So I'd just like to say it can be changed. I think we have to start arguing that point and not just accept that things are just going, you know, down the Swanee. I wondered whether you could reflect on that.
We can reflect on it, but we need to move on, I think. Thanks very much, Andy. And just to say, the College of GPs and the GPC, which is like this sort of more political body of general practitioners, have all talked about continuity until they're blue in the face and got nowhere. Because we... Yeah, but the funding comes with it. If you miss the target, you don't get the funding, so you have even less GPs. So the target is linked to the amount of funding that goes into a practice.